It could be also related to the development of deficiency. Testing vitamin D was also talked about extensively before. We still don't have a full recommendation for general public. We cannot really just say everybody should be tested, but we try to pick up the patients who are increased risk. We don't have really good data about what happens to healthy young and non-pregnant women and young healthy men. Should we test them or not? And we have no studies on outcomes of these young populations, healthy populations, to see if we're doing a good job in treating them. But we try to concentrate on patients or people who are at higher risk. People who get much less sun exposure, dark skin, certain medications, especially anti-seizure, because they also affect the 25-hydroxy vitamin activation in the liver. Medical conditions, specifically the GI and the renal impairment. Pregnancy and lactation could be, and there's a big now field of talking about vitamin D replacement in pregnancy, and that would be better outcomes in the offsprings. We don't have nursing home, but we have patients who reside in hospitals for a long period of time, might consider them as nursing home. And we have a lot also people, elderly people who reside in their homes for many, many months without sun exposure. So these probably would be patients you want to consider them for vitamin D testing. This is also about the storage of vitamin D in subcutaneous and fat tissues might not be having it available for systemic use, and maybe overweight people also could be. If you apply this to Kuwait population, you're probably going to screen everybody. So we still need to clarify who would be the highest risk of developing vitamin D, and probably it would be someone who might have the highest risk of developing osteoporosis and fractures. What would be a normal level? Well, if you go back to the history and look at the guidelines, there's several deficiencies in what could be a clear-cut label. And the Institute of Medicine 2011 said that level of 50 would be sufficient. Endocrine Society in 2011 said that 75 and higher would be sufficient. Amazingly, both came out for the same year using the same data set actually to review. So it was interesting to look at how they both interpreted differently the results. But something could be one of the differences is that Institute of Medicine really concerns about public health. So this could be one reason of differences, because it's concerned about the whole public. More Endocrine Society related to individual patients' care, concerning more about patients who have medical conditions. So this could be one of the things why they look at data differently. So if we're confused, then at least let's agree about patients who are individuals at high risk for deficiencies and developing complications related to these deficiencies. Those patients, you want to target them somewhere around 75 to 150. Patients who have sarcoidosis, you might want the level to be much lower because they already have activated vitamin D higher, and then that could develop into hypercalcemia. Trying to picking up a level of a normal for vitamin D comes from understanding the physiology. So looking at the certain level where the cutoff initiation or stimulation of PTH becomes more obvious is somewhere around the 70s. So below that range, PTH start to be elevated and being produced excessively. So you want a level to suppress PTH as much as possible, and that would be somewhere around the 70s. Also, you want a good bisphosphonate response when you're treating patients with osteoporosis. So it seems like patients who have the least amount of failure or non-response comes from patients who have a higher levels of vitamin D, compared to more percentage of patients who have non-response to bisphosphonates comes from patients who have a lower vitamin D deficiency. This is also very interesting to look at. These are tribes in Africa. Someone went and drew blood to look at their vitamin D levels. Of course, half of their body is exposed to sun. They live outdoors a majority of the time. And their mean vitamin D is actually around 119 and 109. So this is also interesting to see that this is what actually nature would give you in terms of a normal value. So try to keep up as much as possible to these levels. Or maybe these are people who are more exposed, and they should actually have a lower vitamin D level. This is also another part of the argument. So effects of skeletal health, there are several studies looked at it. One of them looked at the fast-paced walking speed, about function of related to vitamin D. And it seems like vitamin D deficiency is related to less in terms of the speed, especially for fast pacing. And this comes from the EBIDOS study, which looked at elderly females doing a prospective trial looking at their effect. Also, looking at the fall prevention, it seems like with the higher levels of vitamin D, there is less fall. This is a meta-analysis of a lot of data we've gathered, and patients with lower vitamin D tend to have a higher risk of developing falls. This is looking at vitamin D and BMD levels. Patients with the higher vitamin D, whether in men or women, tend to have a higher range of BMD, whether in males or in females. And you see the trend is actually statistically significant, going up with the BMD increase as the vitamin D increases. Fracture prevention, also reviewing analysis of a lot of data, doing meta-analysis of these studies, looking at the effect of fracture prevention and the vitamin D level after treatment. It seems like patients who have higher vitamin D tend to have lower risk of a fracture. That was not really statistically significant for hip fracture, but was for non-vertebral fracture. So also some role here possibly of vitamin D and related to fracture prevention. How do we give treatment for these population? Well, if you decide that the target range between 75 or 50, so a lot of patients will need a therapy initially to raise the vitamin D and then keep on a maintenance. And that's also, Dr. Yasser has presented clearly here about the vitamin doses. A lot of societies have made their own judgment of what would be the normal vitamin D dose. If you just compare them just quickly, you will see that very much they're almost the same. They started from somewhere around 400 to somewhere around 2,000 in majority of these guidelines. But if you want to get something, even though you see a little bit differences, but the most important thing, all these doses are safe. And you can safely give someone up to even 5,000 a day of vitamin D and still would be safe. So whatever the dose that you want to decide, you will not going to run into trouble giving these doses. Whether to give vitamin D2 or D3, there's more evidence somehow that D3 seems more better in terms of replacement instead of vitamin D, and it could be because of more effective suppression of PTH. It seems like it has more potency and longer duration than vitamin D2. It's more, that's why a lot of the supplementation comes as a D3. Do we give daily or a weekly or a monthly? It seems like they do almost the same in terms of replacement. So while increasing the vitamin D level or increasing even the activated form of vitamin D or increasing the albumin-corrected calcium, they seem like any one of those ratios or ways of replacement, they do the same. It might be that the daily dose might be less in terms of suppressing PTH compared to the weekly and monthly, and that may be because in monthly and weekly you actually give a larger dose compared to if you give a daily dose. But that's the only tiny difference between them. Otherwise, they're almost the same in terms of what they do. This is also another experiment looking at a monthly dose of 24,000 or a monthly dose of 60,000 and comparing it to a monthly dose 24,000 plus an activated form of vitamin D. A lot of patients on the 24 would reach the target range of 30 nanograms or 75 nanomoles, but more patients on the 60,000 will reach the dose or the level that you want it to be, which is more than 30 nanograms or 75. There's a still hint that maybe with high doses of vitamin D, you might have higher related risk to falls. And that also came from few of data which still needs more exploration to see if this is true or not. These experiments done on oral therapy of 500,000 or IM injection 300,000, all of them reported some risk of related to falls with these large doses. I'm not sure if there is a really clear explanation for that, but that's observation what has been seen. In Kuwait, in the Kuwait Osteoporosis Society, since we have the 50,000 available in the MOH, and that's the majority of places, that's the only available vitamin D supplementation as an oral, then we recommended to use it as a D3, a weekly dose for about 8 to 12 weeks. Depends on what's the lower, the baseline vitamin D. And then after that, you start a maintenance of a dose between 1,000 to 2,000 daily. As Dr. Alessa said, you don't have to measure it, but if you want to measure it, we usually do that only to look at the efficacy of the previous dose and look for compliance also. So maybe you want to measure it 6 to 12 months, 1 year, possibly a lot of patients would be enough to measure vitamin D to look for adequacy and compliance. What's the role of vitamin D in skeletal health? Also mentioned before that vitamin D could help in reducing some of the skeletal outcomes that we look for. This also meta-analysis using doses which are lower, 200 to 600 daily or 700 to 1,000 daily, and looking for risk of falls. It seems that patients using a larger, this is also meta-analysis of several data, looking at the outcome, it's about, the relative risk about 0.81. So there's about 19% reduction in the risk for falls. But that's only in the higher dose. The lower dose did not really reduce significantly the effect. Looking for falls also, there's other trials which looked at the same or slightly different data showing that actually there was no difference in reducing the fall. So this is still going on as in terms of a possibility of difference in outcomes. This is looking for prevention of vertebral fractures with oral vitamin D and dose dependency. This is looking for non-vertebral fractures and hip fractures. Again, large population, about 40,000, meta-analysis of many data looking at vitamin D replacement. And reducing those fracture risk. And it seems like in non-vertebral fractures and also in hip fractures, they were able to be reduced in patients who are getting vitamin D replacement. This is one more meta-analysis looking at similar trials, but additional trials also, as a meta-analysis showed a slightly tending towards positive results, reducing the hip fractures specifically, but it was also non-significant here. This is a large Cochrane review done by Avenel, including participants of 90,000 participants from many data. And it shows here that vitamin D alone is unlikely to be effective in preventing hip fractures. But vitamin D plus calcium result in a small reduction in hip fracture. So as was mentioned before, the combination might have an effect more effectively. And in terms of what would we see in terms of adverse effects if we eat vitamin D, we don't see excess mortality. There might be some hypercalcemia, which is really mild, especially if these patients are on calcitriol, but not the 25 vitamin D. And there might be small increase in GI symptoms, especially using the calcium, which comes mainly from the calcium rather than the vitamin D. And there is also an increase in renal disease, but these patients probably need to be screened better to see if their risk is higher in developing any renal disease related to calcium and vitamin D, especially in those patients who had a history of stones or family history, strong family history of stone, because there was no screening done on these trials. And then there was a last report came out last year in 2018 in October, the famous Bollock studies. This was the effect of vitamin D supplementation on musculoskeletal health. These trials and previous other publications seems like whenever they do it in New Zealand comes up to be negative. But there are still repeated trials done somewhere else to show always positive relation between vitamin D replacement and musculoskeletal outcomes. And in this trial, he showed that actually vitamin D has no role and was not able to prevent any further fractures on these patients or even falls. But the thing about these meta-analysis that was done, the population was much smaller, and about 50% of the trials had participants of more than 200. So you have 50% of them actually have a much lower or smaller number. 70% of trials were only 1 year of duration, so that's one other problem. And a lot of these patients actually were healthy population and normal. 85% were healthy community dwelling patients or people, so you want to call them. So that's probably was one of the things or many things that affected the result of these trials. And only 6% of participants had a baseline of less than 25 nanomoles, which is the severe deficiency who actually would benefit the most in vitamin D replacement. So in conclusion, the evidence of such inconsistency strongly recalls the need still for randomized controlled trials, specifically powered to evaluate whether a low-cost intervention as a vitamin D supplementation could have effect on reducing the risk for falls in older people and to prevent or treat even osteoporosis. So thank you. This is for the first part of the lecture, and then if there is any questions, please, before we move on.